Diagnostic safety, according to the U.S. government's Agency for Healthcare Research and Quality, AHRQ, affects 12 million patients annually in the United States and contributes significantly to the death of 80,000 people. Numerous publications complain that diagnostic errors have received inadequate attention over the last 2 decades of America's investment to improve patient safety. The AHRQ issued a brief in June of 2021 entitled Leadership to Improve Diagnosis, a call to action. This call to action briefing failed to define the cause of the problem. Instead, it focused on a plea for medical leaders to build collective accountability for diagnostic safety. Even the casual reader of this report will come away underwhelmed. The report lacks any significant insight and appears to offer at most minimal success. By contrast, Jason Maud, founder of Isabel Healthcare, a company that has automated the creation of the differential diagnosis, has written a much clearer blueprint for what we need to do to reduce harm from misdiagnosis. Maud begins his 2014 article on this subject with this sentence: "Differential diagnosis has been taught in medical schools for over 100 years, and yet it is not routinely carried out in practice, nor is it required to be documented within medical notes." Maud has clearly accused physicians of not following the recognized method for establishing a correct diagnosis. His well-intentioned accusation acknowledges that physicians today have limited time to do the job of diagnosis properly. But we can't ignore the issue. Jason Maud is not the only person to suggest that the medical community has abandoned its traditional standard. Creating a complete list of possible causes for a patient's condition takes considerable time and energy. A busy physician instead uses his experience to quickly postulate a diagnosis, and then asks questions and collects evidence to prove the accuracy of that hypothesis. Unfortunately, this approach introduces a bias that easily leads to the wrong conclusion. Consider the example of a 51-year-old woman who comes to an emergency room with episodic abdominal pain radiating into her back. A busy surgeon called to see the patient suspects gallbladder disease and requests an ultrasonic examination that does reveal gallstones. The patient soon goes to surgery to remove the gallbladder. The surgery goes smoothly. However, on the first post-op day, the patient continues to complain of severe abdominal pain. That night, the pain seems to grow more intense, and her vital signs become unstable. During the night, despite emergency attention, she dies of a ruptured abdominal aortic aneurysm. She died from an incorrect diagnosis. Dr. Larry Weed, the creator of the problem-oriented medical record, lectured decades ago on the need for computer systems to help physicians create thorough lists of possible causes of a patient's symptoms and findings. Weed recognized that medical knowledge had grown too vast for the human mind to retain and organize reliably, especially in unusual cases. Weed actually worked on a promising system he called knowledge couplers. a system to help his colleagues sort out puzzling cases. The obvious path to improving the accuracy of the medical diagnosis lies in the direction proposed by Jason Maud. Maud argues that we need to require a differential diagnosis for every patient encounter and create tools that make that process rapid and thorough beyond what the human mind can achieve alone. The Isabel Healthcare Project has demonstrated that a computer system can generate a useful differential diagnosis listing the diseases that might produce a specific set of symptoms and physical findings. The next step would combine such an approach to an electronic medical record system to generate a differential diagnosis utilizing all the information available on the patient of interest. Ideally, the software would then suggest optimized steps to efficiently reduce that list to the one remaining accurate diagnosis. We need a name for this diagnostic system built into an electronic medical record. Let's call it the Automatic Diagnosis Under Consideration Generator, or ADUC for short. Let's try to get a feel for the magnitude of this assignment to better understand how it might improve on the current performance of a physician working without assistance. Eventually, we want to diagnose problems before patients experience symptoms. But today, we generally initiate a patient's medical care with what we call the chief complaint. The practitioner starts with the chief complaint and then asks for additional information and then examines the patient to add more information and may then arrange for a variety of tests to add pertinent data to rule out hypothetical but incorrect diagnoses. To understand the scale of the task, we might best start by asking how many medical diagnoses exist. The World Health Organization's International Classification of Diseases, currently identified as the CD10-CM, contains 69,823 individual diagnostic codes. That seems overwhelming. But remember that many of these codes differentiate various severities of an illness. But the ADUC would need to store signs and symptoms for each diagnosis to allow the software to match possible diagnoses to the information taken from a specific patient. So in step 1 of the ADUC process, we have a computer grabbing every diagnosis that might be the cause of our patient's symptoms. About 70 diseases exhibit no symptoms in their early stages, so ADUC would need to always add them into the list of potential diagnoses. The system would also want to make sure to include known complications or side effects of medications and other treatments the patient is receiving. And the system would want to make sure it includes conditions prevalent in the patient's family history. At this point, the ADUC would have cast a very wide net in its search for the patient's correct diagnosis, perhaps a much wider set than physicians normally include in their differential diagnosis. We would still want ADUC to allow the practitioner to easily add and subtract items from consideration to manage unique situations. In its next step, the ADUC needs more information in its database in order to know how to exclude each erroneously proposed diagnosis. It would also be useful to know the lethality or prognosis of each diagnosis to decide on the need for urgency in the patient's condition. Furthermore, it would prove useful to know the cost and risk of each test one might use to exclude a particular diagnosis, again to optimize benefit and safety to the patient. Knowing this sort of information would allow ADUC to apply algorithms to calculate a plan for reaching the correct diagnosis with the best patient outcome and the lowest cost to society. At this point, perhaps you're convinced that ADUC would indeed be a valuable asset in our healthcare system. You may also feel awed that physicians currently appear to get the right diagnosis about 85% of the time without any computer assistance doing such exhaustive sorting and calculating. ADUC does not currently exist. Could it exist soon? Technically, it could. Some hurdles exist. There are two major providers of electronic medical record systems in America today, Epic and Cerner. Epic appears to design its systems avoiding medical decision support that would turn their machines into medical devices regulated by the FDA. Cerner, on the other hand, will become a part of the Oracle Corporation in 2022. Oracle offers advanced expertise in relational database design and would appear ideally suited to creating an effective ADUC. The introduction of the electronic medical record into clinical medicine has not gone particularly smoothly over the last several decades, seemingly because healthcare providers commonly work in an environment of constant interruptions. Using a standard keyboard and computer screen amidst multiple conversations that are typical in a busy clinic or hospital setting commonly makes the computer work go badly. Therefore, anyone creating an ADUC would benefit from the help of industrial designers able to fashion a visual interface that gets the medical care provider to the right diagnostic conclusion despite the usual clinical distractions. You're invited to join the bandwagon to bring an effective ADUC into your nearest hospital. Remember, ADUC is a word that we invented. But go ahead and write a note to the Agency for Healthcare Research and Quality and tell them what you want to address this health risk. Buy a share of stock in Oracle. Ask them to make healthcare safer. Ask your congressman to lean on the FDA to encourage device help to restore differential diagnosis methods in medicine. Or look up the Society to Improve Diagnosis in Medicine on the internet and encourage them to push harder for accuracy. Individuals interested in patient safety more broadly should pay attention to this book. It recasts patient safety as a problem in the management of complexity that deserves the application of all available technology in this arena.